Efficiency Unlocked is hosted by two tech-savvy physicians and dear friends of mine, Doctors Adam Karu and Dale Gold, who are experts in using technology to automate routine tasks and increase efficiency in everyday and business life. Let's see what they have for us today.
Stay tuned for this series of episodes where we'll be discussing the game-changing impact of AI in the realm of patient care and physician well-being.
Get ready to unlock efficiency with NerdMDs.
Efficiency Unlocked.
Yes, and I think it's a learning that many people have, but I'm just going to state it. And it's because I had so many doors closed in my face. In that, when things are hard and you actually are scared, I probably have more courage now as a result of that year in the White House than I ever did before. And we all have this as clinicians, for sure, because we've all had really, really hard times in our training, in our jobs, and just in our identities, being real people, but also being doctors.
That was Dr. Tina Shah, a practicing pulmonary and critical care physician and national expert in workforce burnout, digital health, and health policy. Frankly, a perfect guest for this show. Dr. Shah is currently the Chief Clinical Officer of Abridge, a generative AI company that is cutting down time spent on administrative burden for clinicians and empowering patients. She has served in 2 White House administrations and the U.S. Department of Veteran Affairs, and in 2022 as senior advisor to the current U.S. Surgeon General, where she created the nation's strategy to address the Great Resignation and burnout in healthcare.
Welcome to NerdMD's Efficiency Unlocked. Welcome, Tina. Hey, Adam.
Thanks for having me. Nice to be here.
Yeah, we're super happy to have you. Thanks, Dale.
It's going to be super fun to talk today. Dr. Shah and I actually grew up probably an hour away from each other, and we met on LinkedIn.
That's right. I was exit 8A. What exit were you?
4.
There we go.
So cool. Well, tell us a little bit about yourself. Tell us about your journey into medicine. What kind of inspirations have you had along the way and challenges?
I think I started where most of us did, which was I had fallen in love with science, and I really had like a calling of wanting to help people. And so I think that's where my story started. But I will say, as I continued along that journey and I was in medical school, I started to have like these little things that popped up. The first probably was, ironically, in 4th year when things should get easier. But I had this thought of like, is this the right profession? Like, should I really be doing this? And I was starting to get drawn not to leaving healthcare, but to thinking about healthcare more broadly. How does the system actually work? So I remember having that thought. And then I think I talked to my mom, and she's like, oh, you're definitely finishing medical school. And then you're going to do residency, and then you're going to make some money, and then you can do these other things. And so I followed that, like many others in our basket here. But I will say that never really left me. I wanted to understand the system in which we worked. It did lead me to take a break between 2nd and 3rd year of residency, and I'm pulmonary and critical care. But during my internal medicine residency, I actually left and got an MPH. And it was an interesting year because it was actually the one degree where I went, and pretty much every day I was like, I want to be here. I don't want to be late to class. I want to be here, because it was giving me information that helped pair why folks would come again and again back onto the service because they couldn't afford Lovenox, right? And they developed another clot. I finally started understanding all of the things I had experienced as an intern and as a 2nd year. And after that, and perhaps I'm a glutton for punishment, but I fell in love with the ICU, and I was like, this is it. It's like being MacGyver and being Sherlock Holmes at the same time. And I need to make a small dig at cardiology because my current boss is a cardiologist. But, in cardiology, it's like, well, is it like 81 milligrams of aspirin, or is it like, 325? And in pulmonary and critical care, we were sort of practicing cowboy medicine, right? We were still thinking through hypotheses and trying different medicines. And I was just fascinated by this whole idea of thinking of like how a patient in front of you, and like here are the three things it could be, and trying something out, and then testing that hypothesis and moving the other way. Let's say you give more fluids and then you realize, nope, I should have dried them out. So I had fallen in love with medicine. And here's probably the biggest part about my story. But somehow, when I hit my fellowship, I actually got so burnt out that I was pretty much 100% positive I was leaving medicine. I just had this problem of having student loans. And so I remember typing one day, I was Googling, like, what do you do when you're a doctor, but you don't want to be a doctor anymore, but you need to make money? And like what popped up was pharma, McKinsey. There were a few things. And so as I was pursuing all that, thankfully, I stayed on the track. But I have been working on burnout ever since I recognized that I was burnt out. And it took months. I had the feeling, but I didn't know what it was. But it happened during my training after 3 years when I was in fellowship. And now I think that's my life mission. And as we talk a little bit more, I have always been working on this idea that I think doctors and nurses and PT and OT, they're elite athletes. So we give them all this training, then we put them on the track, which is putting them in US healthcare. And then we shackle their legs and we say, go run the race. And no wonder they can't run that fast. So by my own story, getting fueled, and thankfully I'm still practicing. I was just on service a couple weeks ago, but this is my life mission. And that's really what's led me to be in the White House, to be the senior advisor to the US Surgeon General in 22 and work on burnout, and kind of be in all these other realms, including at a Bridge as chief clinical officer, where I am again focusing on the elite athletes, because if they don't run the race fast, what's going to happen when I need them?
Yeah, I love that story's great. I was just going to point out that Dale and I are family physicians by training, and I don't know if I'm speaking for Dale, but the ICU rotations I did in residency gave me the most stress and indigestion and angst, even though I learned a ton from the fellow intensivists who are great. That was I'll say that was a whirlwind of a month, or 6 weeks, however long it was. But, also good and bad. I'll just leave it in that way.
Fair.
Yeah.
No, it's fascinating. I mean, I think that Adam and I can probably relate that I think we're all realizing some of these different pieces are broken and finding, what approach do we have? I think we have a different approach looking at the healthcare technology side of it specifically, and the physician wellness in terms of EHR training and, and building a better system. So I think we all were looking for ways to help. And, your path is just interesting, especially to me, because it's just, like you said, how do you find these things? And I think that we'll dig into some more of those. I mean, I think the next one to dig into is your work at the White House. That's something that before talking to you, I didn't have a lot of familiarity with that White House fellowship and sort of how you got into that. How did you find it? What was the experience like there for you?
I mean, I could tell you, but I'd have to kill you. In all actuality, this was really interesting. So following my trajectory of getting burnt out, I continued to search, and I had actually trained to be a clinician scientist. I wanted to follow the money in medicine. Around that time, the reimbursement penalties were settling in for people getting readmitted back to the hospital. And I had thought originally that's going to be my life's work, looking at the impact of how when financing changes, what happens to clinician behavior and patient outcomes. But I had a mentor who said, hey, you're kind of policy focused. Why don't you think about this thing called the White House Fellowship? And it was created in the 1960s by President Lyndon Johnson to address this problem of brain drain. There were all these intelligent people who were staying in the private sector instead of going into government. So this is actually a program for mid-career professionals, all industries. And the whole goal is to take people committed to public service, so they've already demonstrated that they have contributed in this way in their industry, put them in government for a year. So these are folks that have never been in federal government, but put them at the highest levels. And if you thought the ICU was stressful, Adam, my boss was a cabinet secretary. And he was a doctor as well, Dr. David Shulkin, who was the secretary of the U.S. Department of Veterans Affairs. But that was the first and only time I had heartburn for like 2 months. It was such an incredible program. So one piece was rolling up your sleeves and working day in, day out at your placement. In my case, I was VA's first director of clinician well-being, and very relevant to you both, did quite a bit of work on in-basket message optimization in primary care, where we actually published a paper showing that we were able to give about an hour and a half back for PCPs per week because we got rid of really low value messages. There was a second piece that was trying to understand how the world works. How does transportation work with what the Department of State does with housing and urban development, and how does that pertain to healthcare? And we had a track where we would meet at least twice a week with leaders in the public and private sector and have those off the record question and answer sessions where we could really understand how these leaders grappled with some of the biggest decisions our countries had to make. And I got to throw this in because one of those lunches that we had involved Colin Powell, and this incredible leader, he just nonchalantly rolled up in his red Ferrari, parked on the side, came in, and we had the most incredible lunch trying to understand, all of the different things he had to navigate, from his identity being a Black leader in the military to helping the country navigate geopolitics over all those years. And then the third piece of the fellowship was honestly the camaraderie and the learning off of your colleagues. And I will say I probably talked to, my cohort was 16 people out of thousands that applied, but I still talk to probably the astrophysicist, actually I don't want to name names because I talk to a lot of the fellows, but there's something about learning off of people in different industries that I think is amazing for us to pull back in healthcare, and I'm forever grateful for that. But I also have a duty to now contribute to my country, which I think people are trying to hold me accountable for.
Oh, that's awesome. I mean, those examples you just gave are so cool to hear. I mean, I guess the follow-up to this that I would have is, is there something that you feel like you took away from that experience where you've now since applied it, either in kind of your clinical space or in any of your endeavors now? Is there something that you kind of really just say this was like the golden nugget out of that experience?
Yes, and I think it's a learning that many people have, but I'm just going to state it. And it's because I had so many doors closed in my face, in that when things are hard and you actually are scared, I probably have more courage now as a result of that year in the White House than I ever did before. And we all have this as clinicians, for sure, because we've all had really, really hard times in our training, in our jobs, and just in our identities, being real people, but also being doctors. To me, that was probably the biggest thing, because I think I was always outside of the box, but the White House Fellowship really highlighted that. And when I left, I didn't have an immediate next place to go. In fact, when I left the White House, I was unemployed. That was my job. And I'm not saying the fear is gone, but what I have now is an acknowledgement of the fear, and then I go on. I'm not sure I would have been able to be where I am today in the same way or at this time. Maybe it would have taken me longer if I hadn't learned how to manage my fear and keep going and take risk.
No, that's great. I mean, I love how in this journey that started with some burnout, instead of taking the easy way out, it seems like you keep taking the harder way out and looking for a bigger challenge to solve this problem. And I think it's super impressive. I definitely wouldn't want to go next to you as we introduced ourselves and said our interesting facts, because I can't compete with any of this. So let's transition to more about burnout. I kind of want to understand a little bit more about your involvement in that history of burnout. What do we know that works to solve burnout? What we don't? And if you could kind of define healthcare burnout to the audience as well before you get started.
I'd love to. Here's the best part about burnout. It's not a me issue, it's a we issue. Burnout's actually an occupational diagnosis. It's not a medical diagnosis. And we colloquially use burnout, whether we're physicians or clinicians or we're in other industries, but in our world, there's a very specific definition. And it comes from the 1970s. That's really where the origin of burnout. And there was this incredible researcher and leader named Christine Maslach, and she creates the Maslach Burnout Inventory. And essentially, that's our foundation. You need to have one of the three following feelings when you think about work. When I think about work, do I feel emotionally exhausted? When I think about work, do I feel detached and cynical? And for me, that manifestation really hit home. I remember thinking about patients a little bit less as people and a little bit more as things to do and tasks. And I think we've all dealt with that from time to time. And the third one is, and this is so ironic, but we all have it too, it's a feeling of lack of accomplishment when you think about your work. Truth be told, we're doing heroic works every day that we're on service, and even when we're in healthcare working on the administrative side, for those of us that do. But when you're burnt out, when you think about work, if you have one of these three qualities, then you fit the diagnosis of burnout, which is due to your workplace largely, and to a very small degree, our individual selves. However, if we are depressed or we are anxious, or certain personalities, I'm just going to name perfectionists because I often fall into that trap, it does tend to have some influence, but by and by, burnout is a workplace issue and it requires workplace interventions. So thinking about what can you actually do? This is all about looking at system interventions. We know the days of pizza and yoga are dead. And I mean, I think those two are good things, but they are insufficient, right? The biggest bang for your buck is, can you do something at the system level? I like to think about 4 buckets. And I actually think tech could really touch all of them, but I'm curious what both of you think. So here we go. The first is giving input. Anytime we have a lack of input, we actually get burnt out. And so are there mechanisms at the system level to bring that back where the front lines can give input? The second is anything that inhibits our ability to provide quality care. Let's say the MRI machine's down, right? And your neurology or neurosurgery, that is going to cause burnout. So fixing anything that hinders our ability to provide quality care. Efficiency, and I know we're going to hit on this one, but anything that makes us inefficient is going to also cause problems. And then the last one is a free one. It's the lack of recognition for the daily works we do. And so if we can actually at a system level build that culture in of recognizing these heroic deeds, because that's what we do every day, those are the 4 treatments for burnout, broadly speaking, at the system level. So curious, Dale and Adam, thoughts?
Yeah, I mean, I love that. Like, I've never heard of like those 4 kind of buckets being put right together. I actually jotted it down as you were explaining them because I wanted to glance back. And I also obviously I now I'm reflecting on, the companies I've worked for and kind of like, oh, we've done this or we've done this. I think, obviously I think Dale's in my wheelhouse has always been this inefficient piece, let's try and make processes, workflows, the technology match the ideal state, to minimize that efficiency for both the patient and the care team. But I don't know, I guess my observation would be, I guess in my experience, I've seen all of these implemented. I feel like a lot of times what happens though is one of them will start, or maybe a couple, and then there's this really good kind of inertia with it, and they're frequently done and seen, and then there's this petering out effect. And I don't know, I think that's probably the challenge from a system level is to, I mean, you mentioned this, but it has to be baked into the culture of the company, the culture of the workforce to keep enforcing it. Yeah, Dale, you got any thoughts on this one too?
Yeah, I think that, like you said, I think it's hard to commit to all of these. I think that's probably a big piece of it. And, also the recognition piece was interesting to me. I know that's something that I've talked about in my work recently. And I think it's hard, just like you said, with the pizza parties, it's hard to really put your finger on recognition. And I think maybe the closest example is back when we were really in the middle of the pandemic and, people were just so grateful to speak with you and work with you and for the work that we were all doing. And, that was probably the recognition that had the biggest impact, versus any pizza or yoga party, despite how fun they all are. It's just sort of that recognition and that, that respect and that support, from everyone around you of what's happening. I think that's probably a big piece of it. But I think there's a lot of pieces to it. And I think that, you've got a lot of history in this. I think it's really interesting also, you're now the chief clinical officer for an AI company. What do you think about AI in the future lending itself to helping solve some of these burnout issues that, maybe we've struggled with at the first rollout of technology in healthcare?
There's so much promise. I'm going to say my statement is there's so much promise. We need to implement AI now, and it's not going to solve our multiple decade problems that, in my opinion, largely go back to our fee-for-service environment. So I'm a realist, but I'm sitting inside a company and literally using this tech every time I'm on service, and I'm 30% clinical working in the unit, and I am feeling a difference in my cognitive load. So we have the ability of AI today in 2024, and actually we really had it in 2023, where the lowest hanging fruit, which are the things we do that fall under gross or getting rid of stupid stuff, all of those things that we do that are more like data entry versus critical thinking, that's probably the first place where we should be implementing AI. In this case, as chief clinical officer of a bridge, we started out with, can we address no documentation? And I think folks spend very little time to a lot of time. And if I recall, there was a study published that said on average, docs spend 1.77 hours per day after clinic writing notes. So even if you're really good, on average, that's what we have in our industry. If we use AI to do things that are repeated, works that we do all the time, but are low risk, that's going to help us because we have two hits. One, the direct work I'm doing, typing my notes after I round or after I see patients in clinic. It's literally taking up time where I could have been talking to patients. But the second thing is it's leaving me with residue, and it's coming in two forms. One is the big B, burnout. It's contributing to my burnout. And then because I have this workplace condition, I'm not as effective as a doctor as I could be. In fact, people that are burnt out have less empathy, but burnout's been linked to negative outcomes in every aspect of the quintuple aim. So it leads to poor patient experience, poor patient outcomes, increased cost of the healthcare system. This is massive. The second residue, and I'm most excited about this because this one is something we can measure with a validated tool, and AI can show an impact in a day, even as short as a day. And we're actually doing those studies in a bridge right now to prove what I've said publicly on this podcast is measuring cognitive load. And I'm just going to share something. I think for people listening, probably during this time that you're listening to this podcast, you have been interrupted, I'm going to guess, at least 5 times, but probably more, right? Whether it's your smartwatch, your phone, your wife, whatever it is. Every time you do that, you actually lose some of your finite brain battery in just switching attention from one place to another. So these kind of things that are low value, going back to medicine now, writing notes, responding to patient messages that are low level that we don't need to, getting 3 pop-ups instead of just getting one message or never getting that message at all. A lot of that is stuff that we can take the laser beam of AI on and deploy on because it's costing us in a major way. It's creating patient safety issues. We're so overloaded. And I have to share this because it's like the most disturbing thing I've ever heard. And I have this slide every time I talk about burnout, but the chronic stress coming from cognitive overload literally changes your white brain matter in the areas that cause short-term and long-term memory loss and also cause poor medical decision-making. So this is why I go back to my original statement. AI works. We need to deploy it now, with the parentheses of in certain places that are low risk and could be, where we do low value work. But it's not going to solve burnout because we still have massive issues with, how we deal with prior auths, how we're paid, and what we need to document just to get paid.
Man, that's powerful. The especially that changing of the brain matter, that's affecting this. Because, if there's these physiologic changes that are happening as a result of this, That's no, that's it's troubling, but it's great that we're like, acknowledging this and talking about this type of stuff. Is and I also heard, you open this up and saying that in a bridge, you're trying to figure out how to actually kind of quantify almost this like cognitive burden, because I think that's the stuff that's hard. As a clinician, you can get caught in the swirl. As a professional, you can get caught in the swirl of many things that are, and it reaches a tipping point. Like you get to a point and you can no longer truly process, what's even right in front of you. And that's, it's troubling. I think, especially, I would say for physicians who kind of know some of these clinical manifestations of those symptoms, that can also be troubling, because then you start to go, well, do I have something wrong with me? Or is this just truly this cognitive load that's overloading? Now, very interesting. Personally for you, has, using either, the Abridge tool yourself or something like, can you share something in your life that has kind of where like, oh, I used this and it helped at least kind of chip away, like you described, at some of this?
I absolutely can share. And I'd love to share an example of how I've been using Abridge. So just to set the stage, Abridge actually started off by trying to summarize medical conversations for patients. So a slightly different use case and I think this is so great, and probably why we're physician founded. Otherwise, we probably wouldn't have focused on patients first, right? But taking everything that happens in that clinic visit in that room and summarizing it down into normal language so someone could remember it and have like a written remembrance of what the heck happened. And then we moved over to doing the equivalent with SOAP notes. We are really, really out there in terms of trying to help folks on the ambulatory side. That's actually where we started, especially in primary care, where the burnout is the highest. And also the stakes are the highest for our country. So that's actually why we started in primary care ambulatory, although we're in 55 specialties now. I wanted to give an example, though, of an off-label use, which is on the inpatient side. And it's not that it isn't here yet per se, but I call it off-label because we want to bake it to where it feels seamless, and we're still working on it, just being open and honest. But I do feel like my cognitive load has changed, because I'm seeing anywhere from, I don't know, on average, I would say like somewhere between like 8 to 16 patients a day, but they're very complicated. I think, as you all know, we have some incredibly complicated patients, even in the hospital as well. And if I'm writing the note, I'm blasting through seeing everyone in the morning, hoping no one codes, and then at some point sitting down and writing the note. If I'm on a teaching service, the same thing is kind of happening, except I'm getting that note probably when I leave after 5 p.m. So then I'm stuck looking at my chicken scratch printed patient list and remembering like, what were the top 3 things or the top 5 things? And Abridge has actually been my second brain. So what I did over 2 weekends ago was actually use Abridge to capture everything that was discussed between me, my fellow, sometimes a nurse, sometimes a patient if they gave consent. And when I went back to either attest these notes as the attending or write the notes myself, I actually had this really much more comprehensive summary of what I had done than my usual status quo. That made me feel good, because I often go home and can't sleep because I'm like, what did I miss and what did I forget, even as an attending? I think we all have that still. So that's been pretty interesting. But also, one of the things I did was actually a pulmonary consult with my fellow. And I have so much respect for the trainees right now, because my fellow probably was getting paged or called every 3 to 5 minutes. And that's just not doable. So going back to the task load, right, and the brain power you lose by switching, it's a miracle that the fellows are as good as they are, given how much we try and make their lives hard. And at the end, we wrote the note together using Abridge, and he's like, "This is awesome. I want to use it again. I'm actually on consults next week, and we get something like 15 to 20 news a day. And I want to use this because I don't want to miss anything." So there's something there. And when we keep looking down the line, what else can we knock out with AI? So like at our company, we're looking at the entire arc of what causes us cognitive load. Imagine if your orders were kind of there. Like, remember when you could give verbals to your nurse? Some of us still do that. Some of us can't. Some of us have MAs. But imagine if AI did that for us. You can kind of see like how many times do I spend responding to these negative messages of, can you adjust? What type of heart failure was it? Was it acute or was it chronic? All of those coding queries. Imagine if that was taken away because the note was better to start with, but also the AI helped the coders. And we're actually working on that too. Give us credit for all the things we've been doing anyway. So you can kind of see where we're going. I could go on and on, I'll stop, but I already can say that my practice is shifting and I'm feeling more present.
No, that's amazing. I've used a similar tool for the last couple months, taking my own notes in the outpatient setting, and I can totally agree that cognitive load being removed is just such a relief. Even if you're not churning out double the volume, it's having that time to connect and sort of focus and pay attention versus worrying about, let me write that down, let me get that note right, and my notes are more accurate. They have different information that's better that I may have missed, and I'm also able to listen to the entire conversation. It's really showed me that I can't multitask as well as I thought I could. It's pretty clear, but it does make you hungry for more, right? Like, I think as soon as, I don't know if you've seen this with people adopting your technology, that as soon as you sort of get the taste of it, you're sort of ready for like, okay, this is standard of care. This should be here. We should all have this. This is not, as impressive. This is just something that I should have to do my job. And what's next? So I don't know if you see that. And when you do adoption with other users, if they're ready for the next step once they've seen that.
Yeah. And I feel really lucky in that I'm working in a company with a technology, because AI means so many different things to different people, but I can probably speak the most to our companies, although I know many other AI companies have this too. The tech is so seamless that once you get over the skepticism hurdle, which I think we all have and should continue to have, where we're like, no one better give us another thing to do, another onboarding, another training. But once you get over that, and in our case, it was so user friendly. I actually only onboarded for a few minutes and then a patient coded, so I had to leave. So once you get over that hump, I do think people are hungry for more. And it's a good sign when people are telling you flaws with your technology because they're like, can you make this now? Can you make this happen now? It's incredible. So to me, this is like, if we were to go macro on this, well, what kind of conditions do we need to create in the US so that this technology doesn't die on the vine or doesn't stay in the places it usually goes to, which are academics and other well-resourced places where we practice that can take this, because we need to get this out everywhere. People are hurting.
No, I agree. I hope this tool at some level can be, something that's available to all, all providers, all caregivers, beyond even physicians, anyone taking care, that this is things that outside of healthcare, people could download an app today and do this. I think that it's our duty in healthcare organizations to make sure that we can find a safe way for providers to do this and protect information and have it available. And I think that's what a lot of Adam, myself, and other counterparts are working on. I want to switch gears for a second because you are really the expert on something called prior authorization. I think that's one of those get rid of stupid stuff. Would you mind telling us a little bit about what that means to our audience, and what are we doing today to improve that, and where does the future look like?
Dale, I think you're the first person that ever called me an expert on prior authorizations, and I'm pretty sure it was a compliment, but I'm also feeling uncomfortable. But no, in all jest, man, it doesn't that, I feel like every single physician has multiple stories, or maybe there are a few that are okay with what's happening and they figured out a way to get around this process. But I describe prior auths as an insurance tactic that requires the insurance company to be in the office visit too. As in, you decide something with your patient and their caregivers. You come up with, okay, we need another medicine. I'm going to write you a prescription. I'm going to refer you to someone. I'm going to get you, we need to do, a CAT scan. But you can't actually do it, right? Prior authorization is that extra step where you need to get pre-approval by sending a tome of evidence, and not in an easy way. although we are electronic, that manifests in having multiple different web pages, portals that you have to go to submit the data. And then in many cases, as is the case in New Jersey where I practice, payers have 15 days to respond. Now, if you have someone with an acute issue, that's inappropriate. And there was a JAMA paper published in the last 6 months that showed 25%. It was appalling what they showed with cancer patients. 25% are having serious delays in care. The overwhelming number of cancer patients surveyed said that prior auths were, I think the word was horrendous. It was some very, very strong word when they used it on a Likert scale to say, like, what was your experience with prior auths? We already know this on the doctor side, but on the patient side, same thing. So it has morphed from, hey, we want to make sure that we help patients get the right care at the right time, to a very obvious, we've just, the snowball effect has happened and it's being misused. And it's so bad now that there is much more patient harm than patient benefit, and it needs to be reined in, but the train has left the station, so it's very hard to pull it back.
Yeah, it's interesting because I know in the news recently, there's been at least a couple mentions of, some of the payers, using some technologies to kind of like decline some of these things. At a reported pretty high fidelity. I think there's some court cases, that are going on right now. But I guess, on the flip side, because this train has already left the station, do you see kind of any emerging innovations in this space that you think are going to be able to help us? I've heard obviously some inklings of this, with, throwing out that AI term again, but is there anything that you think in the prior auth space has really caught your attention?
Yeah, and maybe we could talk about it in two different flavors. One is what tech can do, and one is what's happening on the policy level. Because I think those are the two hottest things in the prior auth game. On the tech side, what I don't want to happen is AI bots fighting AI bots. And we're kind of seeing that now. As you mentioned, Adam, there was actually, I think, an expose by ProPublica that talked about how AI was being used on the payer side to deny prior auths to such a rate that it was inconceivable that a doctor was looking at the chart. It was something like 100 denials in an hour, right? That means they're not opening the patient's chart. But on the other side, and I won't lie, I've tested this out. Have you all gone to Doximity to try their prior auth tool? And I know there are tons of others, but there are these tools out there that are like using AI to help you write something and help with either the initial prior auth or the denial. I still think, I'm glad we're having that innovation, but one is at the lowest level on the tech side. Let's get rid of the stupid stuff. We don't want our MAs, our nurses, our doctors spending any of their time having to be these manual data entry people and submit this data. So what's the tech industry going to do on that? I think the use of AI to pull out this information from the EHR or wherever else is a simple one. We also need to see the seamless transfer from our EHR into the payer's hands, which we don't have yet, although there's some regulatory hurdles with that. So that's what I want to see, and that's the lowest level. There also is this thing that we've been talking about internally as a company, and I think a company like mine, Abridge, has a lot of potential here. If we had really, really accurate notes, because I don't think it's a problem of what we're doing in the visit, it's a problem of what gets documented about the visit. If we had really clean notes, we should have less prior auth denials. So I think there's something there. But further, and we're coming up with our strategy, we're going to have a strategy to try and lower the prior auth burden. And I think this is what happens again when you have two doctors that are sleep deprived because we still try and practice, leading the helm amongst many other clinicians in our company. But if you're really embedded as an AI company and you have access to see all this data as it's coming through, whether you're listening and summarizing the conversation, or you're on the back end with billing and coding, or even you're on a payer platform that's connected to your EHR, we finally have the transparency we never had on how many things were denied, why were they denied, which specialties were they denied in, what happened afterwards, what was a turnaround time. We've never been able to hold payers accountable. So I think these are some examples of what's going on in my mind about the role of the tech industry to completely unblock us from this, honestly, many times dangerous process that's implemented ubiquitously in US healthcare. And on the policy side, now I can talk about something really exciting, which is there is a game going on, and this game's being played at the state level. And I think we're winning. I mean, we're like only on the second inning right now. And in this case, there are 50 innings because there are 50 states. But I want to share something about New Jersey. Is that okay? Can I do that? Okay.
Yes, please.
Okay, great. So this is like a victory that I think we need to celebrate, because in Jersey there was a bill that had been introduced in 2018 to regulate prior auths. And you can imagine that it really hit a lot of resistance, but it got introduced again. So last year we were looking at this, and myself, a bunch of other people, doctors, nurses, and patients, thinking about what could we do on prior auths. And we actually mobilized a group of folks, again, doctors, nurses, and patients in Jersey. It resulted in us sending thousands of letters to our legislators. And it shifted from legislators telling us, no doctors reaching out to us, this thing's not important, it's a shortened lame duck session, this is not going to get passed, ain't going to happen, even though they're pro clinicians but saying this, to getting TikTok influencers to like shed light on what's happening in Jersey, thousands of letters. Hopefully we'll have a couple articles coming out soon. But a near unanimous passing of this. We only had one dissent when we looked at the Assembly and the House, and the governor signed it into law last month. And it's going to go into effect January 1, 2025. And you know what? Now prior auths, if it's urgent, it's not 15 days, it's 24 hours. And if we don't hear from the insurance company, it's automatically approved. That's crazy. Now there's transparency. Now, again, I still think there's a role for AI companies to really give us an unbiased view of what's happening with denials, but insurance companies have to report in Jersey the denials, for what reason and what specialty. We're also required to be able to access another clinician, in this case, specifically a doctor that's from the same specialty. We never had that before. And I'm sure both of you can attest to this. Like, I can't believe we don't have this right now, but I mean, it's not okay to have someone that doesn't understand your specialty deny care that's like life-saving for your patient. And the list goes on and on. There's quite a few other things, but it's probably one of the strongest pieces of legislation we've seen in the last 5 years. And after this, we have 29 other states and a total of 80 bills that are active right now in the country, just at the state level, not to mention what's happening federally. So I am pumped. And the question is, what can our community of listeners in to this very podcast, what can we do collectively? Because I think there's a lot.
I think that's amazing what you've done. And, what you're sharing. I think that as much as we all, Adam and I, other physicians, know pieces of this, a lot of us are working, like you said, and not reaching out. And I think you bring up some great points of what could happen if we did.
And we don't have time, right? We understand. I mean, I don't want to say I'm trying to blame the victim, because I don't want anyone to feel like they should have done more. We are so tired at the end of the day. But I was shocked. I think our group probably was a core of 10 people in Jersey and maybe an activated group of 100 people. But it only takes a small group to get a bill signed into law in a state.
No, that's awesome. Speaking of time, we're going to transition to our Nerd Alert lightning round. So you've made it through the hard part of the show, and now you can just relax and have some fun. I don't remember all of the rules, Adam, but I think it's like a minute or 2 minutes, some amount of questions where just some short answers, have some fun. You can pass if you want to pass. And maybe Adam will do some sound effect editing of like a timer and a bell at the end, depending how busy his week is. I don't know. But are you ready to jump in?
Yeah, no rules. No rules at all. Have fun.
No rules.
I'm in. Let's go.
All right. First question I'm going to ask, because we just had the Super Bowl. For the Super Bowl, are you football, halftime show, or commercials?
It's Usher. What can you say? Halftime, 100%.
Love it. How about favorite health tech gadget you can't live without in your clinical role?
Man, that's tough, because what I wanted to say was my fellow, but if it was a health tech gadget, I think it's the ability to see the EHR on my phone. I know it's kind of basic, but it is game changing.
No,
that's great.
How about moving to your daily routine? What's a go-to efficiency hack, app, website, something you use to make yourself efficient? I know you work 3 jobs and you're advocating. What is your efficiency trick?
Oh, that's interesting. I have started to look at, I actually do use, I think I'm going to switch to Superhuman, but I need help with my inbox. And how do you sift through the BS and really find the important messages that you want to respond to? But I'm also going to offer something else because I'm a de-implementationist. Like Superman, this is my superhero, my superpower, and I want to grow it because sometimes I need more of it in my life. But lately, I've just been closing all the tabs that are open on my web browser, and I do think it's making me more efficient.
That's a great tip. I know the browsers, like, they save that state now. So it's like, even when you quit, you open it up and it's like, boom. And then immediately you're like, oh, what's that 4th one? Yeah, that's great.
Right. It's like, it's negative reinforcement to the fact that you still haven't, you still screwed up, that you haven't done the task, but we need positive reinforcement.
That's exactly right. If your job had a theme song, what would it be?
Oh my God. You know what comes to mind? Started from the bottom, now we're here. Hydration.
Love it.
Love it. Hopefully Adam plays it in the production.
Yeah, we got to be careful. Copyright. But Tina can sing it, so we're good there.
We're good. Coffee or tea for your sleepless working nights?
Tea.
That's great. And one word to describe your relationship with EHR?
Ambiguous.
And best way outside of work that you deal with the stress?
I can't say I have that licked yet. I think it's a daily struggle, to be honest. Probably spending time with people I care about.
No, I love it. No, that's great. Thank you so much for these questions and for being here. Before we end and wrap up, anything you want to plug to the audience?
I think I just want to say thank you, because after all this talk about burnout and how we don't get recognition for what we're doing, I know you're an elite athlete. I know folks that are listening in are elite athletes, and hopefully you don't find this too fluffy, but I'm thankful. And I remember when I was sitting in the Surgeon General's office, I would tell this to my friends because they never get to hear it. Our doctor friends never get to hear it. But we are doing incredible work, and I see you, even if others don't.
No, that's a great note to end on. So it's been a pleasure having you on it. It's been fun to do this with Adam and I both on this episode with you. It's been great. So thanks everybody for listening to NerdMD's Efficiency Unlocked. Until next time, stay tuned for more episodes.
Thanks, Tina. It was a pleasure chatting with you. Thanks for taking time.
Yeah, this was amazing.
Thank you for listening to Efficiency Unlocked, Nerd Tested, MD Approved, a NerdMD's podcast by Drs. Adam Carew and Dale Gold.